Hi folks, I thought I'd give you a bit of a resume of my experience with LumenEye, which I used recently on a patient who'd been diagnosed with a mid-rectal cancer. I hadn't done the actual endoscopy and I met her for the first time in clinic, and traditionally we would want to check the height of the rectal tumour from the anal verge and puborectalis using rigid sigmoidoscopy, which, as I'm sure you're all aware, is a mixed feast. Often in an unprepared rectum you may have either no view or a very limited view of the tumour, which is of limited value in some cases. So being able to get an augmented view gives a massive advantage. So in this case we did not use glycerine suppositories beforehand, although this would have been easy to do and would have given absolutely endoscopic first-rate pictures. But we did it unprepared and got fantastic views in the upright position. Didn't need to bend down and have the patient's soles of shoes rubbing on my head, so it was ergonomically very good and excellent pictures. And if I'd needed to, which I didn't in that case, I could have passed the endoscopic biopsy forceps down the channel for repeat biopsy. I was able to check the height of the tumour, and in this instance the patient, who was a medical practitioner, was keen to look at the imaging. Find it very informative. It's obviously not appropriate for all patients, but it was in this instance. So that was really helpful. And if I'd wanted a second opinion, given that the system connects online, I could have had an opinion from another specialist anywhere in the world. I can see immediate applications in the outpatient setting for second opinions on radiation proctitis, ulcerative proctitis, specialist input from gastroenterology colleagues as to how that would be best managed, and also looking at the response to treatment. For example, after a course of mesalazine type suppositories, we often rely on the patient's history to tell us whether it's been effective or not, and we may not feel the need to do a formal flexible sigmoidoscopy to confirm that the condition has abated. So we do a rigid ziggy in the clinic, but again with limited or no views, and we often satisfy ourselves that it's settled. But with LumenEye you will get a proper look and be able to again share with colleagues online to see if any further treatment is needed. Other outpatient applications that I can see would be very helpful. Any indication that you would be using a rigid sigmoidoscopy, the LumenEye will give you a much better view. And clearly, if you want to formally get the patient to have a couple of glycerine suppositories in a neighbouring toilet and then do the LumenEye, you will get first-class views that you would get in an endoscopic with a flexible sigmoidoscopy. Other indications would be, as I've mentioned already, if there's a suspicion of proctitis or inflammation, you will get a much better view, and you may even be able to do the biopsy there and then. You might see the upper extent of the proctitis and therefore not require formal flexible sigmoidoscopy and be able to do biopsies for histological confirmation. So you can start treatment there and then, rather than waiting for what can be 4 to 6 weeks for an endoscopy before the patient gets some therapy. Watch and wait for those that have had a complete clinical and radiological response for rectal cancer. Currently, to get the best views, often an endoscopy is arranged in the endoscopy department, but after a suppository, LumenEye will be able to look at and survey the scarred area, biopsy as well down the channel,